Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. I've been in practice for more than 40 years. The focus of this presentation is ACC AHA 2017 guidelines related to syncope diagnosis and treatment. This presentation is based on the article reported in the Journal of the American College of Cardiology in 2017 with reference to evaluation and management of patients with syncope. You can get a free copy of this by just Googling the title, and you can download a PDF which you can use as a reference for yourself, and it will be a great resource when you face a patient with syncope. Before I get into the main presentation, I do want to introduce my cardiology quick reference manual, which you can get a free copy of this manual. At the end of this presentation, I'll tell you how you can get a free copy of this manual. It covers many guidelines, and also it covers a whole lot of things that are useful to medical students, nurses, residents, fellows, primary care doctors, cardiologists, internists, and anesthesiologists and emergency department personnel. So this will be a great resource, and you can get a free copy of this, and I will tell you how you can get a free copy of this at the end of this presentation. So let us continue with the main feature presentation. Syncope is the most challenging symptom that we face as cardiologists or as any other specialist, because syncope could be a multi-system, multi-specialty challenge. It can be cardiac, it can be neurological, it could be metabolic, it could be physical, like people pass out when you stick a needle in them, or they are hurt, or they get injury, people pass out. It could be psychological, it could be drug-induced, which is very commonly seen in the cardiology population, especially when they are on polypharmacy, as they call it. It could be just related to their wear and tear of the autonomic nervous system, or sometimes we may never find out what is causing the syncope. But we are going to focus upon the cardiac causes for syncope. There are a variety of conditions within the cardiovascular system that can cause syncope. I may not be able to cover all of them, but here are some broad classifications like bradyarrhythmias, tachyarrhythmias, ventricular arrhythmias, structural heart disease like cardiomyopathy, or ischemic heart disease, valvular heart disease, hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasia, cardiac sarcoid. These are all just the tip of the iceberg when it comes to trying to find out what is causing syncope in a given patient. Here are some congenital conditions like Brugada, short QT interval, long QT interval, catecholinergic polymorphic ventricular tachycardia. I've never seen a case like this. Early repolarization. So this is just like a partial list of the cardiac conditions that can cause syncope. But when we are faced with a patient with syncope, we have to make a concerted effort to narrow down their symptomatology, presentation, physical examination to see what is causing syncope. And here we have more conditions just within the cardiovascular system like vaso-vagal syncope, pacemaker-related syncope, carotid sinus syncope, reflex conditions, orthostatic hypotension. This is one of the most challenging things for a cardiologist to deal with. When they are standing up, they pass out. When they're lying down, their blood pressure is 220 over 120. What do? Neurogenic orthostatic hypotension, dehydration, and then finally pseudosyncope. So this is just the beginning of the symptoms. But history taking is of paramount importance. I'm not going to go through each one of these lines. I would like you to just pause this for a couple of minutes and look at each one of these items, because every line is important in trying to ascertain as what is causing the syncope. First of all, we need to find out what was the person doing before syncope? What happened just before the syncope? What happened during the syncope, if the patient can recall? When did the patient wake up? How did the patient feel when the patient woke up? Was there a witness? What did the witness see? What is a recount of the witness as that person saw the person passing out? Did this person have syncope before? How often? For how many years or months? What are the underlying medical conditions? What are the medications the patient is taking? What other changes have happened in the last month or a week or days? Has there been unusual stress? So the list goes on and on. Is this related to exertion? Is this related to exercise? Is this related to posture, lying down versus standing up? A whole host of things need to be asked to try to narrow down the list. Is this cardiac? Is this neurogenic? Is this metabolic? If someone comes with a hemoglobin of 6 and say the patient passed out, at least very quickly we know what we are dealing with. First of all, we need to replace the blood. And second, we need to get their vital signs up, make sure their oxygen level is up, their blood pressure is up, their heart rate is okay, all these things. But there are situations where we may have real challenge as to find out what is causing the syncope. We have to do a systematic history taking and a systematic evaluation. The physical examination may or may not give us very many clues unless we are dealing with a patient with a physical trauma or an internal bleeding or like a shock or having an acute myocardial infarction. A lot of times we may not hear anything, but still as cardiologists, we need to pay attention to the details. It is the minute points that makes the difference. What is the pulse? What is the blood pressure? What's the pulse oximetry, saturation? What is the skin texture, color? Are there cold extremities? How many of us listen to the carotids to look for carotid bruise? What's the heart rate and rhythm? Do you hear any heart murmur? Do you feel any gallop? Then we need to do a quick neurological exam. Can the patient move all the extremities? Can the patient speak? Can the patient remember the past couple of instances in their life? Can the patient move their muscles? Then we move on to the examined test. Of course, cardiac monitoring is the first thing that we do when somebody comes into the emergency room. Then we do an electrocardiogram to rule out any acute cardiovascular events. We can only rule out ischemic heart disease, tachyarrhythmias or bradyarrhythmias or complete heart block, things like that. But if someone is having an aortic dissection, we may not be able to do anything about that. A chest x-ray and a quick echocardiogram would be of value in patients who are unstable to see if there is any evidence of aortic valve leak or aortic dissection or pericardial effusion, things like that. And then we have more routine tests like tilt table tests and event monitoring, which I'm going to talk about in a minute. We need to assess the risk when we see a patient with a syncope. Is this a patient with multiple medical problems who has had syncope in the past, who is on multiple medications? So those are high-risk patients. Are we dealing with a patient with a history of arrhythmias, atrial fibrillation, or recurrent VTAC? They are higher risk candidates. Are we dealing with patients who are on blood thinners, who have a tendency to bleed? They are of moderate risk or high risk category. But if you're dealing with a young teenager who passes out while getting COVID vaccine, that's not as serious as someone with a bleeding. So this is a patient who can be treated conservatively. Is this metabolic? Is this related to dehydration? Does the patient have seizures? So all these things need to be assessed. Transient loss of consciousness. This is one of the flowcharts from that 2017 ACC guidelines. If you suspect syncope, if you think it is not a syncope, then we need to look for other causes. If we suspect syncope and you say, okay, this is definitely a syncope, then we do the initial examination evaluation, which is class 1 indication, which of course everyone is expected to do. Then we need to look for certain causes. As I said, if someone passes out while they are getting an injection or blood drawing, we know what caused this one. And in that situation, we can keep this patient on bed rest, elevate the legs, get them from some fluids. If they feel better, maybe they can be followed up as an outpatient. Whereas if that is not the case, we need to do the risk assessment. As I told you, the history is so important in determining the risk of this patient in the presence of syncope. Once we do that, we see if we can narrow down the cause of syncope. If we cannot narrow it down immediately, we need to look for further evaluation, which we'll talk about. So the challenges from a cardiac perspective are we dealing with valvular heart disease, arrhythmias, heart blocks? Is this vascular related, like vascular collapse we see in a vasovagal syncope? Is this neurohumoral? Is this psychological, stroke, metabolic, hemorrhagic, trauma? Serious medical conditions present. If you say yes, of course we follow that pathway of what condition does this patient? Does this patient have slow heart rate? Heart rate is 30 and the blood pressure is 80 over 60. Of course, we are dealing with a bradycardia with hypotension. We need to follow that bradycardia protocol. If the patient is having an atrial fibrillation with 200 heart rate, we have to follow supraventricular tachycardia. I'm just giving you examples. That's the case. If that's not the situation, we manage presumptive reflex-mediated syncope in an outpatient setting. If we are dealing with syncope in a patient who was outside in a real hot environment, but is not severely dehydrated and his mental condition is okay, we can treat them in an outpatient setting. We give them fluids, give them oxygen, and once their vital signs stabilize, they can be followed as an outpatient. If somebody gets a bad news and they pass out and they are feeling weak, then we hydrate these patients, send them back for further evaluation by their family physician or a cardiologist. A structured emergency department observation protocol for intermediate risk patients. So now we are talking about intermediate risk patients. Someone who has been vomiting, throwing up for 2-3 days and has not eaten anything, who is dehydrated and passes out. That's not somebody you want to send them home immediately, or even just give a liter of fluid and send them home. If their vital signs are unstable, they need to be admitted for observation or followed for a protracted period in the emergency room if that's something that's feasible. Dehydration, and same thing with medications, because medications are not going to disappear in a few hours. It may take 24, 48, 72 hours for the medications to clear from the system. So in that case, they need to be closely monitored and appropriately treated. Cardiac syncope as an outpatient setting. I already talked about when patients can be treated in an outpatient setting. If we know a clear reason, like somebody passes out because of an injection or because of drawing blood, or there was some physical trauma and the patient has recovered, feeling better, then they can be treated as an outpatient. All right. So here are some of the cardiac conditions which we have already mentioned. Pulmonary embolus is another important thing to think about. Aortic dissection and acute heart failure are some of the things that we need to consider, because these are all high-risk patients. Additional evaluation and management. So we already done all these things. Now, initial evaluation is unclear. So we're trying to got an electrocardiogram. Maybe it is not showing any acute myocardial infarction. Maybe it doesn't have a bradycardia, but then what do we do? Of course, we proceed with some blood tests. We need to look at blood sugar. We need to look at electrolytes, potassium. High potassium in a renal failure patients can create bradycardia and syncope because of hyperkalemia. Or is there a significant drop in the hemoglobin, especially cardiac patients who are on double antiplatelet anticoagulant therapy or maybe triple therapy. So that's something to keep in mind. If the initial evaluation suggests neurogenic orthostatic hypotension, they need to be referred for autonomic evaluation. This is the most challenging field, especially in the elderly population, when they have orthostatic hypotension. That is, when they are lying down, their blood pressures are normal or high, and when they stand up, their blood pressure drops. What do we do? There are certain things that we can do, which we'll talk about in a minute. And evaluation for reflex or vasovagal syncope. Reflex syncope, we can do a tilt table test. This is class 2A indication. After that, if we are dealing with patients with like structural heart disease, things like that, or arrhythmias, we can do a cardiac monitoring. There are varieties of cardiac monitoring, which I will touch upon in the coming slides, and they can be treated in the ambulatory external cardiac monitoring, or if they need a pacemaker or a defibrillator, depending upon the type of arrhythmia we are dealing with. These cardiac patients can also undergo stress testing to rule out any evidence of reversible myocardial ischemia. Echocardiography is an important aspect to look at structural, functional aspects of the heart. And of course, electrophysiologic studies is like a class 2A indication. All these are class 2A indication, and MRI and CT are class 2B indication. But let me tell you, if somebody goes with a syncope with history of medical problems, first thing they're going to do is CT of the chest. Then they may do MRI also. I'm just telling you what happens in the real world versus what the guidelines say. I talked about different types of cardiac monitoring. We have a Holter monitor which can record for 24 to 48 hours. They are good if it can pick up a particular arrhythmia or long sinus pauses or runs of atrial fibrillation with rapid ventricular response or frequent ventricular tachycardias, short bursts of ventricular tachycardia. It may help, but it doesn't help us to understand, is this causing the symptoms, and are they all related to the patient's symptoms? Because they may have multiple episodes, but not all of them are causing symptoms. Extended monitors can be placed like patch monitors that can monitor someone for 14 to 30 days. And the yield is still only 24% of them they were able to pick up supraventricular arrhythmias as a cause for the patient's symptoms. So not all these tests are able to pick up, especially if the symptoms are infrequent. Then we have transtelephonic, then we have an extended loop recorder, which can detect arrhythmias in 75% of the time the loop recorder, the patients have arrhythmias. And the most significant one is the mobile cardiac outpatient telemetry, which can pick up arrhythmias in 88% of the cases. And of course, the best one would be implantable cardiac monitors, like the one we put under the skin, which can be functional for anywhere from 9 months to 3 years. And that will pick up every heartbeat in that patient, and that is probably the best way to do it, but not everybody needs it. If we know somebody is having a heart rate with 30 with long pauses, and if you put a pacemaker and the symptoms get better, we are done. We don't need to, put an implantable cardiac monitor in those patients. This is an invasive procedure, even though it's a very simple invasive. You just made a little incision in the skin and you just insert this pallet under the skin and you're done. There are no electrical wires to be connected or anything like that. And this can pick up every heartbeat for the duration of its battery life. Okay. Now a word or two about vasovagal syncope. When people have vasovagal syncope, some of the things that happen is with high vagal tone, there is vasodilatation combined with slowing of the heart rate. When you combine slowing of the heart rate with vasodilatation, there is pooling of blood in the splanchnic area and in the lower extremities. As a result, patients become dizzy and they pass out. And they can sort of feel it when it's coming, that initially they may feel a little woozy, but before they can even realize what is causing this, they may pass out. We have some countermeasures that can be done to prevent these people from getting hypotension or drop in blood pressure. If they have high vagal tone, by keeping their intravascular volume high, at least we can increase their intravascular volume so the drop won't be so dramatic. That can be done with increased salt and fluid intake. We can also use some countermeasures, which is class 2 indication. And if these things don't work, we can use midodrine, which is a class 2-1 indication, which increases vasomotor tone and it helps to get the blood back into the main circulation. Then we have all these items which are class 2B, where the response is plus minus. But if it helps, we can try it. Otherwise, best thing is to stop them because the patients may have side effects from these drugs. Fludrocortisone, beta blockers, orthostatic training. Orthostatic training should be done no matter what, because people need to learn how to avoid this. And especially for older patients, when they get up from the bed, we need to tell them to exercise their arms and exercise their legs and trunk muscles, so the blood gets back into the main circulation before they stand up. And when they stand up, we need to tell them to just pause for a couple of seconds to see if we have a steady balance. If not, just lie down and try to get your blood pumping again before you start walking. Serotonin reuptake inhibitors, I never use this. As cardiologists, we don't use it. And of course, dual chamber pacemaker or CRT may help to maintain optimal cardiac output in these patients. And here is a suspected syncope of orthostatic hypotension. And when the systolic blood pressure drops more than 20 and the diastolic pressure drops more than 10, then that is an indication to look for neurogenic orthostatic hypotension. And here are compression garments, counterpressure measures, midodrine, droxidopa. I never use droxidopa, but it's used by neurologists for particularly patients with Parkinson's disease. Fludrocortisone, even that I have not used. Main thing is increase their volume, and of course pyridostigmine. We used to use pyridostigmine in cardiac patients, but we haven't used this recently. And of course, cardiac drugs are notorious for causing postural hypotension, and that's why we need to monitor their blood pressures lying down, sitting up, and standing. And if there's a significant drop in blood pressure, we need to kind of balance between syncope versus severe systolic hypertension. Of course, if it's related to dehydration, I already talked about that. So, ladies and gentlemen, orthostatic hypotension is a real challenge. The key points are it causes pooling of the blood in the splanchnic area and in the lower extremities. This is a defective neurogenic response to change in posture. It loses vasomotor tone. And of course, some of the other conditions that can make it worse are medications, dehydration, diuretics, vasodilators, and I already talked about what they need to do in terms of physically exercising and maybe trying some medications. Psychogenic pseudosyncope is a syndrome of apparent loss of consciousness occurring in the absence of impaired cerebral perfusion. Most of what we have talked up to this point is related to reduced cerebral perfusion, which leads to like turning off the lights in your brain. But this is the pseudosyncope or psychogenic pseudosyncope. It's a condition where the cerebral perfusion is normal, but these patients feel like they are passing out. It is just a psychological sensation, and it has nothing to do with the circulation as such. But of course, whatever it is, it has to be addressed. Otherwise, these patients are going to continue to feel those symptoms. So, ladies and gentlemen, now we come to the end of this presentation. All you have to do is send me an email to Dr. Nik Nikam at gmail.com. I'm going to put the email address in the bottom, and I'll be happy to email you a copy of this cardiology quick reference manual. And before I close, I want you to just let you know we have a series of ACC AHA guidelines all the way from 2013 up to 2022. The most recent one is the heart failure guidelines. I have produced videos on every one of these topics, not all of them, many of these topics, and please do watch them, and please do subscribe to our YouTube channel. I will see you in the next presentation. Thank you so much for your time.